Welcome to today's webinar, Medicaid, the Health Reform Expansion, Taming Cost, and More, brought to you by NCSL. At this time, all lines have been placed on a listen-only mode to provide favorable sound quality during today's presentation. It is now my pleasure to turn the floor over to John Kuhl. Sir, the floor is yours.
Thank you. Hello, and thank you for joining us today for NCSL's 2013 Top Issue Webinar Series. My name is John Kuhl, Public Affairs and Media Manager at the National Conference of State Legislatures, and I will be moderating today's webinar. Each year, NCSL develops a list of the most pressing and important concerns on state legislative agendas. Today, we have a panel of NCSL issue experts that will be discussing Medicaid, everything from Medicaid expansion as a result of the Affordable Care Act, to how to keep costs down. Our experts include Melissa Hansen. Melissa is a program principal for the health program at NCSL, and has been with the organization for 6 years. Melissa's portfolio of topics include state Medicaid policy, minority health, and primary health care. Melissa holds a BA in economics and a master's in public health. Laura Tobler. Laura is the program director for NCSL's health program. Laura oversees all state policy work related to Medicaid, insurance exchanges, primary care, injury prevention, and adolescent health. Laura holds a master's in public policy and has been with NCSL for over 17 years. Megan Kamlasi. Megan is an NCSL policy associate and works on issues ranging from Medicaid fraud and abuse to minority health and adolescent health. Megan has been with NCSL for 3 years. She also holds a master's in public policy. Following the presentations by our panelists, we will have a question and answer period. To submit a question, please use the chat feature. It's on the right-hand corner of your screen, and we'll try to get to as many of your questions as possible. Thank you again for joining us, and with that, I'm going to turn it over to Melissa.
Great. Thank you, John. Today we were asked to talk about the latest state actions related to expanding Medicaid under provisions of the Affordable Care Act that was effectively made optional by the June 2012 Supreme Court ruling, and to highlight state innovations to improve the value of Medicaid. That is a ton of material to cover in a short time. So first, for any new legislator or legislative staff, I'm going to review why Medicaid matters to states' healthcare systems. Next, I will highlight recent state actions regarding the expansion, and then give a very brief overview of cost containment strategies. Then I will turn it over to my colleagues to address 3 of these strategies in more depth: managed care, long-term care, fraud, waste, and abuse reduction. Medicaid is a top issue in 2013 because it costs states a bundle. Medicaid accounts for about 15% of state general funds. If you throw the federal match dollars into the mix, that number is more like 21%. In some states, it is as high as 34%. Also, Medicaid costs continue to rise and put pressure on state budgets. In fact, in an NCSL survey of state legislative fiscal staff, 34 states reported that Medicaid is the top fiscal issue for the 2013 session. As this chart shows, the next issue, education, was selected by 23 states. Medicaid is also an important issue to states because it covers about 20% of the non-elderly population nationwide. These percentages differ from state to state. This means Medicaid is a source of health coverage for kids, pregnant women, disabled individuals, and the elderly poor. On the other side of the coverage coin is the providers for which Medicaid is a significant payer. This chart shows that Medicaid is an important source of financing, paying for about 32% of nursing home care in the U.S. and about 19% of hospital care, meaning that any major change to Medicaid affects the business model of providers in our states. But perhaps the number one reason state legislatures are addressing Medicaid policy is because the consensus is that states can do better and get more value, that is, a better quality of care at a lesser cost. To improve the value of Medicaid, states have to know what drives costs in their states and where there are quality gaps and inefficiencies. For example, as this kind of busy chart created by the Kaiser Family Foundation shows, nationally about 5% of Medicaid beneficiaries account for about half of Medicaid spending. Looked at just a little differently, this chart shows that nationally, while children comprise the bulk of enrollees, they do not drive costs. Conversely, you can see that the disabled and the elderly make up a small percentage of enrollees, but account for a majority of expenditures. Another reason that Medicaid is a top issue for this session is the optional expansion available to states. Federal health reform expands Medicaid to adults aged 19 through 64 with incomes at or below 133% of the poverty guidelines, or effectively 138% if you account for the 5% income disregard that is also included in the law. The law outlines that states will receive 100% federal medical assistance percentage, often referred to as FMAP rate, for the newly eligible population to 2016. FMAP is the percentage used to determine the federal matching funds allocated to states for Medicaid. FMAP rates for newly eligible beneficiaries are gradually reduced after 2016. The Supreme Court's ruling on the constitutionality of health reform did not change the Medicaid expansion provision, but effectively allows states to opt out of the expansion without facing the penalty of losing their FMAP match for their current Medicaid enrollees. Since the Court's opinion, states have been trying to figure out the positive and the negative of Medicaid expansion. So have many interest groups. There have been many studies analyzing the expansion and its impact on states. Policymakers want to be sure they understand the underlying assumptions of any research. All future projections, be it for future enrollment or the cost, will include such assumptions. But it is important to understand the rationale used by the research to come up with their outcome. It is also difficult to compare study to study because of this. Many of the studies make different assumptions, and therefore it is like comparing apples to oranges. But there are some costs associated with the expansion that states want to consider. First is the cost of the newly eligible. As I mentioned, the federal government will absorb the direct cost of care for these individuals through 2016. However, due to the heightened media attention and the individual mandate stating that everyone needs to have health insurance or pay a penalty, people who are currently eligible for Medicaid but not enrolled might be more likely to enroll in the program. These people are not eligible for the enhanced federal match. This is a cost increase states may face, whether they expand or not. This is often referred to as the woodwork effect. Finally, states must consider additional administration costs associated with the expansion. There are also some possible cost savings available to states. If a state has previously expanded coverage to newly eligible groups through a waiver, those patients may receive the enhanced match, may not receive the enhanced match under the expansion. Also, if coverage is expanded, the costs associated with care for the uninsured could go down. The federal law counts on this and reduces disproportionate hospital share, or DISH payments, over time. We will talk about DISH more in a second. There has been a lot of media speculation about which states will expand or not expand Medicaid. This is a list compiled using multiple news outlets. Many of these assumptions are based solely on the governor's comments. But the bottom line at this point is no one knows yet. As this slide shows, what we do know is that legislatures will be actively engaging in the discussion. Legislators have been filing bills to expand, to not expand, to encourage their governors to act, and also bills doing some other interesting things. For example, Colorado has a bill that prohibits the state from cutting K-12 education funding to pay for the expansion. And Missouri has a bill that encourages the federal government to distribute DISH dollars in a way that does not penalize states for not expanding. In the last few months, many important questions have been asked of CMS, the federal Medicaid agencies, and they've been answered. Is there a deadline for expanding Medicaid? No. This means that states do not have to expand by 2014 if they want more time to study the issue. It is important to note that the 100% FMAP match is not available for the first 2 years the state expands. It is only available for 2014-2015 as outlined in the law. Do states have to expand to everyone's incomes up to 133%? Yes. This is important because some states were interested in expanding to 100% of the federal poverty level and allowing people above 100% to get subsidized insurance through the health insurance exchange. Once expanded, may states roll back eligibility? Yes. So if a state expands but their projections are wrong or the fiscal situation changes, they may roll back the expansion. Do states have options on how to adopt modified adjusted gross income as the methodology to determine income eligibility? Yes, they have sent clarity on that. But there are many questions that still need to be answered. As I mentioned before, most people agree that a higher percentage of people eligible for Medicaid will enroll. But a big question is how many of these people will enroll? Referred to as the uptake percentage, some states are dealing with big numbers. So the difference between a 10% uptake and a 90% uptake could mean significant cost differences in the state. Also, the DISH issue is complex, so I won't go into details here, but how those reduced dollars are distributed to states by CMS may significantly impact safety net providers in the state. Finally, looking forward, what are the medical needs of the newly eligible population, and what are the costs of those needs? Is there provider capacity within your state to adequately meet the needs? Do you have enough behavioral health specialists? Do you have enough substance abuse specialists in the state? Finally, there are some concerns with the ongoing budget discussions at the federal level whether or not the enhanced FMAP match will be sustained. There's also questions whether we truly understand the administrative costs associated with the expansion, and does the Medicaid program within the state have the personnel and the expertise to expand Medicaid at this time? Next, I want to talk a little bit about cost containment strategies. But before we dive into these strategies, it is important to note that Medicaid is a program within the larger healthcare system and is, relative to other components of healthcare, efficient. According to John Houlihan at the Urban Institute, although Medicaid spending has grown faster than the rate of increase in national health spending, much of this is explained by increased enrollment. Per enrollee, Medicaid spending actually compares favorably to increases in medical care prices and gross domestic product. With enrollment growth being largely driven by underlying economic conditions, some argue that building a robust economy is the way to reduce Medicaid spending. Medicaid costs are also affected by overall health care inflation. Furthermore, nationally, state Medicaid administrative costs are lower than you find in the private market, meaning, in general, state Medicaid programs are lean. Another thing to consider is that states serve as the laboratory of innovation for Medicaid. Not every policy option states are implementing has been proven to contain or reduce costs. Though not proven, states are hopeful that these actions will contain costs over time. When creating innovative policies to address Medicaid costs, many policymakers are looking at ways to ensure that patients are getting the correct care in the correct setting and at the correct time. According to Feeman in the National Review, speaking about health costs in general, said, Controlling costs is all about incentives for employers, for consumers, for healthcare providers, and for insurers. Some policymakers, frustrated that their Medicaid reforms and cost savings were being absorbed by other market forces, are looking to address overall healthcare costs in their states. These efforts are often difficult, requiring multiple players, private insurers, Medicare, and Medicaid, to coordinate and work together. These efforts often require some upfront investment, and the system change and associated cost savings may take years to realize. However, they aim at actually changing the market or bending the cost curve. There are two ways states are experimenting with changing overall health care costs. First, some states like Vermont, for example, are investing in wellness programs aimed at keeping people healthy and therefore not requiring expensive medical interventions. Second, states such as Arkansas, Minnesota, and Oregon are working with other payers to implement market-wide payment reforms to align incentives. It is important to note that sometimes actions or policies that save the system and the state money actually cost the people implementing those policies, such as providers or managed care organizations, money. For example, a hospital-based program that aims to reduce readmissions and emergency room visits for asthmatic youth may contain Medicaid costs and improve kids' lives, but actually reduce hospital revenue. To be successful, all payer reforms need to have some mechanism to share savings with all stakeholders. While we're on the topic of sharing, I wanted to mention some states, California, Ohio, Rhode Island, for example, are looking at ways to increase beneficiaries' involvement in their own care. One way is through charging premiums or copays. One issue with copays is that without an enforcement mechanism, they are very hard to collect. Historically, creating enforcement mechanisms has been difficult. However, a recently proposed rule indicates that CMS may be willing to work with states on these efforts to increase shared responsibility. NCSL will keep its members apprised of this in the future. Other policies are looking at payment reforms, delivery system changes that are targeted directly at the Medicaid program. For example, states are looking to establish Medicaid medical or health homes or accountable care organizations within their Medicaid programs. Health homes have been very well studied and have been found, if implemented correctly, to add value to Medicaid. Around 34 states have some form of medical home within their Medicaid program. States such as Oregon, Colorado, and New Jersey are experimenting with ACOs. There is very little data on Medicaid ACOs at this time. However, NCSL will be keeping up on the research and will keep our members informed of what this research finds. As an entitlement program with inherent risks, budgeting for Medicaid is difficult. Policymakers are exploring policy options that at the very least allow for some predictability and ideally will stabilize cost increases. Laura and Megan will talk about managed care and fraud and abuse in more detail later. I did want to mention that Utah and Massachusetts have both looked at ways to tie Medicaid growth to the growth of the economy. Some states are focusing on high-cost patients. Laura will talk about dual eligibles and long-term care in more detail, but I did want to share one hotspotting example. Hotspotting is geographically mapping Medicaid expenditure data to identify areas or individual hotspots. These people are often referred to as high utilizers. Once these patients are identified, they are given intensive case management. The Camden Coalition of Healthcare Providers in New Jersey has early results that show intensive, individualized, coordinated care that includes social services for 36 of Camden's highest utilizers, cut monthly hospital bills totaling $1.2 million in half. Finally, over the last 4 years, many states have faced budget deficits that require immediate cost savings. Cutting benefits, limiting eligibility, and reducing provider reimbursements have been the three usual suspects used by states for short-term Medicaid cost containment. Federal health reform requires states to maintain their March 2010 Medicaid eligibility level, eliminating a key tool from the legislative arsenal. At least 46 states made a benefit or provider reimbursement change in 2012 to reduce program costs. However, it is worth noting that while these changes do cut the cost immediately, they don't actually change the value of the program over time. Next, I would like to turn it over to Laura to discuss in more detail how managed care options can help save money.
Hello, and good morning and good afternoon, depending upon where you are in the country. I'm going to focus on two topics, managed care and long-term care, and which includes some comments about dual eligibles and recent initiatives that states are working on. So let's start with managed care. And for those that are new to the Health Committee, either as staff or as legislators, you know, this slide will provide you with an outline of Medicaid managed care as it is right now. It's not new to the Medicaid program. Managed care has been used by states for quite some time, starting back in the 80s for Arizona. And so there are many states that have a lot of experience with managed care, and then there are those that are new to it. So when we say Medicaid managed care, what we're talking about are three really different kinds of programs. Comprehensive risk-based programs, which are the managed care that you're probably more familiar with in your own personal insurance. That's the one that's associated with a managed care company, an HMO. Limited benefit plans are risk-based, but they're more selective in what that covers. So it might be just covering mental health or substance abuse. It might just be covering dental services. And then primary care case management is really just intensive primary care management of individual beneficiary. And the states that have implemented these programs typically target certain diseases, certain chronic diseases, where they know they're going to get return on their investment in the primary care case management. So how comprehensive risk-based works is it's done on typically a capitated system where the state has a contract with an HMO or an MCO, and they are paid a lump sum to provide the contractual services. The limited benefit plans are capitated based on that selective service. And then primary care case management, the primary care doctors that are seeing the Medicaid patients are paid a per member per month fee to provide care management for those individuals with chronic diseases. And that is one area where I'm going to show you a map of the states where when we talk about some of the challenges with managed care and Medicaid, for rural and frontier states that don't have the managed care infrastructure and the companies to be able to provide the services and to contract with, primary care case management is one area of managing care where rural areas have done some work, and you'll see that in some of my following slides. The other thing about managed care with Medicaid is that it can be voluntary or mandatory. So the state can exempt certain populations, and they can allow for voluntary enrollment, opt-ins and opt-out provisions, and they can also mandate enrollment. And what we're seeing trend-wise is more states going towards mandatory enrollment. Medicaid nationally really is a managed care program. more than 70% of beneficiaries are enrolled in Medicaid managed care. And at this time, what we're seeing is that most states are either planning for or discussing expansions. So that number is just going to increase in the future. Historically, mandatory use of managed care has been focused on low-income children and parents, but what we're seeing is that more states are looking at enrolling new populations into their managed care programs, such as the elderly and people with disabilities, and also looking at expanding managed care for those selected services like behavioral and mental health services. And many states are also pursuing managed care for their new programs to coordinate care for the dual eligibles, which we'll talk about in a few minutes. Research shows that if a state takes their time and implements a managed care program so that it is successful, that it can have positive effects on quality, and it can at least predict costs for the state because of the capitation. So let's look at some of the things that the research shows. It can improve care coordination because you have that managed component. So you're no longer paying on a fee-for-service basis. You're paying for someone to coordinate the care for those that have chronic diseases, and that's the population where we do see increased management can reduce costs for those, especially those with multiple and complicated chronic diseases. It can improve access to providers in underserved areas. So the managed care organization becomes the partner with the state in making sure that the network is adequate, and the managed care organization is responsible for helping to recruit those providers onto their network. There's a caveat here, though, with the potential increase in the number of people that will have insurance in 2014, especially in those states that will be expanding Medicaid to 138% of poverty. The managed care organizations have reported that they're concerned about being able to build an adequate provider network. So although they're your partner, and although historically there are states that have shown that having managed care has helped them to build their provider network, there are definitely concerns with the increased number of people that will have coverage, concerns about whether or not there will be the providers out there be able to pull into the network. It can improve quality and accountability, and accountability is probably the key here, because the contract that the state has will have those items outlined for the managed care organization that's working with the state. It can provide incentives for preventive care, which down the road, as Melissa said, helps overall save on health care spending. It could also save on long-term care spending, which is a big dollar area for states. It can address inefficient use of health services, so the state in their contract can roll in things like reducing hospital readmissions, reducing inappropriate use of the ER by requiring 24-hour nurse hotlines and other strategies to accomplish that. And finally, and in some ways, more importantly, it can provide financial predictability for the state. So this is the map that I was talking about. It is dated, but it is the most recent data that we have. So it's October 2010. It does come from the Kaiser Family Foundation, and this shows where the nation is with comprehensive Medicaid managed care penetration by state. So the darker the state, the more managed care. And this map actually includes all of the methods of delivering services through managed care. So it also includes primary care case management. So when you're looking at this map, you'll see Arizona. They are fully capitated, full risk managed care. And then you'll see Idaho and South Dakota are also very dark, very rural states. You wouldn't expect them to have a high penetration of full risk capitated managed care, but they have a very high penetration of primary care case management. So this just gives you an idea of where the nation is right now with their Medicaid managed care penetration. Going on to some of the new things that states are looking at, which is one of them is looking to managed care to help improve the quality and reduce the cost for those receiving long-term services and support. So we're seeing this area grow pretty rapidly when you look at the historical growth of managed care in general. So managed care for long-term services and supports has grown significantly. In 2012, there were 600,000 enrolled in this type of delivery system, which is up from 68,000 in 2004. There's 15 states, up from 7 in 2004, and of the 15 states, 11 are statewide or in multiple counties. When we were first seeing states delving into managed care for long-term services and supports, most of them were doing it in just their most populous county. Now we're seeing a desire to move that statewide. This map shows you the states that are currently implementing programs of managed care for long-term services and supports. And the source dropped off of this. This is AARP's map. And this shows the states planning to implement new managed long-term services and supports programs in their Medicaid programs. If you're out there and you know your state is talking about these topics or that they're actively pursuing implementing a program and they're not on this map, please let us know so that we can update our data. We always like to know when we're wrong. As you probably know, there's a major focus on dual eligibles right now. Dual eligibles, or I should say correctly, dually eligible. My boss told me there's no such thing as a dual eligible. So those that are dually eligible they're a pretty significant group of individuals. There's 9 million who are eligible for both Medicare and Medicaid. They're also some of the poorest and sickest of beneficiaries, and that translates into an expensive group to provide coverage for. So they account for a disproportionate amount of spending, and I'm going to show you a pie chart that will help us look at that. So they account for 16% of the Medicare beneficiaries, but 27% of the spending, and they account for 15% of Medicaid enrollees, but 38% of the spending. So there is a significant amount of work being done by the Centers for Medicare and Medicaid Services and also by the states in partnership with them to control the costs for this group and to work on integrating the care. So in the past, there were these two very separate programs providing care for these folks who are complicated and complex to serve. And so there's more work on trying to coordinate that care and to integrate the financing. So in the past, if there was savings that were incurred because the Medicaid program was doing a great job of reducing the cost, in the end, Medicare may realize those savings. So there's a program that was created by the Patient Protection and Affordable Care Act, and it will help states to realize and share some of those savings. So the ACA created a new office within CMS, the Medicare-Medicaid Coordinating Office, to coordinate care for people eligible for Medicaid and Medicare, so those that are dually eligible. Their mission is to align the care and the financing and increase states' access to Medicare data, which will also help states to get the job done. They have two models for states to pursue. They've already picked 15 states that received design contracts to create demonstrations to integrate care for dual eligible individuals, and that was launched back in April of 2011. And the 15 states are California, Colorado, Connecticut, Massachusetts, Michigan, Minnesota, New York, North Carolina, Oklahoma, Oregon, South Carolina, Tennessee, Vermont, Washington, and Wisconsin. They also have a duals integration project, which is more related to the financing and the coordination. And there are 26 states that are moving forward with proposals to participate in the duals demonstration project. And the CMS website reminds us that just by putting a proposal out there doesn't mean that it's final, so they're still in many states being reviewed. But you'll see that there's definitely a wellspring of interest in addressing the not just the cost of care for those that are dually eligible, but the quality of care. So by integrating the care, the goal is to improve the quality of care to these folks who are high users of the system. So some of the things to think about if you're involved in this conversation in your state is that one size will not fit all. So even though we have these 15 states that are out there sort of testing this idea, and we have ideas and lessons learned from other states, various approaches are going to be needed to address each of these individuals' unique needs. So when you're engaged in these conversations, keep that in mind. And probably the most important thing to keep in mind is that the current landscape definitely offers room for improvement, and that there's also not a lot of research to show what the savings will be to the states for these programs, so don't count your savings before they're hatched. In other words, there's few results to date that have shown cost savings, although the hope is that that will be one of the results. The other area related to long-term care where we're seeing lots and lots of innovative and successful programs is around Medicaid home and community-based services. So the PPACA also had multiple provisions to promote and encourage the use of home and community-based services, which, by the way, every state uses in their Medicaid programs and had in place prior to PPACA. But what PPACA encourages is more use of home and community-based services. So currently every state is using them in some capacity. So 49 states in D.C. are operating at least one 1950C waiver, which is the home and community-based service waiver, and Arizona does it through their 1115 waiver. 43 states in the District of Columbia are participating in Money Follows the Person. So Money Follows the Person originally was set to end in 2011, and it gives states an increased federal FMAP for individuals who are able to transition from institutional care into home and community-based services. So there are 43 states in the District of Columbia that are participating in Money Follows the Person. And then applications have been approved for balancing programs. The balancing programs are this will provide qualifying states that agree to increase their home and community-based service spending by October 1st, 2015, with either a 2 or a 5 percentage point FMAP increase for those services based upon the amount of non-institutional Medicaid spending on long-term care services in fiscal year 2009. To qualify, states must develop a plan and submit an application to HHS. And then the Community First option, currently states must have an approved waiver to place Medicaid beneficiaries in home and community-based services, which is a time-consuming and lengthy process. Beginning October 1st, states can amend their Medicaid plans to include home and community-based services. So 5 states have submitted state plan amendments to create Community First programs in their states: Arizona, California, Louisiana, Maryland, and Minnesota. I'm going to move on here to show you a map which shows that nursing and institutional expenditures almost double home and community-based service expenditures. And so that was the impetus for including those provisions in the Affordable Care Act, was to try to nationally move everyone into home and community-based services when it's appropriate. Research does show that that's where beneficiaries prefer to have their services, and there certainly are states that have successfully implemented programs where we can get value from the lessons learned from those programs. And I don't have a slide, but I am going to say that I want to mention that Melissa mentioned improving the health status as a way to reduce costs. Improving the health status is also a significant way to reduce the demand for long-term care. So as states invest in wellness and prevention, long-term, down the road, they're also investing in reducing the demand for long-term services and support. And now my time is up, and I'm going to turn it over to Megan, and she's going to talk to you about Medicaid fraud and abuse.
Thank you, Laura. Moving on to Medicaid fraud and abuse, it's difficult to quantify just how much money states lose to Medicaid waste, fraud, and abuse, but estimates suggest that it's in the billions of dollars every year, so you can understand why states care. And not only is Medicaid waste, fraud, and abuse costly, but it diverts taxpayer dollars that would otherwise be spent on legitimate health care services. Not only that, but it can impact the quality of care by subjecting patients to ineffective, unnecessary, or even harmful treatment. So for the legislators and staff who are on the call who are new to the Medicaid arena, I've included this slide so that when you hear these terms, you know kind of what people are talking about, what the jargon is. Fraud is essentially an intentional deception made with the knowledge that it can result in some sort of unauthorized financial gain. Examples include kickbacks to doctors, upcoding, which is billing for more expensive procedures than are provided, or in the case of a pharmacy, billing for a brand name prescription when a generic is provided. Abuse is any action that's inconsistent with accepted practices, whether physical, business, or medical, and includes such things as the provision of services that aren't medically necessary. Waste is a related but somewhat different issue. It's generally unintentional and encompasses overuse of services or misuse of resources, as well as simple billing errors. And Medicaid program integrity really has to do with proper management of Medicaid. It includes administrative functions, such as enrolling and screening providers, as well as oversight through audits and data reviews. And then also deals with recovering payments that shouldn't have been made. And I think it's important to note that anyone can defraud the system, whether it's Medicaid beneficiaries or providers, but really the majority of fraud, waste, and abuse is concentrated among providers, and that's where, when states are going after it, that's where the big money is. So there are multiple agencies at both the state and federal levels that are involved in Medicaid program integrity activities. Every state Medicaid program has a program integrity component, and while these are generally within the state Medicaid agency, some states have independent offices of Medicaid program integrity that just gives them that extra independence. Program integrity units are a bit different in every state, but common functions include activities to identify and prevent fraud, such as certifying Medicaid providers and making sure they're legitimate and providing services to who they say they are, educating providers, conducting audits, and then recouping Medicaid funds that were inappropriately claimed. Program integrity units also work closely with Medicaid fraud control units and other law enforcement and regulatory agencies. Every state, by federal law, is also required to have a Medicaid fraud control unit, and all states do, with the exception of North Dakota, which has a waiver. Medicaid fraud control units are state-based law enforcement agencies, and most are located within the state attorney general's office. They're responsible for investigating and prosecuting Medicaid provider fraud, as well as investigating complaints of abuse or neglect in facilities that are funded by Medicaid. And then at the federal level, the Centers for Medicare and Medicaid Services also clearly have an interest in reducing Medicaid fraud and have many ongoing initiatives and work closely with states on fraud and abuse, primarily from their Center on Program Integrity. The Patient Protection and Affordable Care Act included numerous provisions to strengthen state program integrity efforts. So I've listed a few here, and I'll go over them. But it increases provider screening and enrollment requirements. Essentially, the Affordable Care Act designates healthcare providers as either low, medium, or high risk. And based on that designation, there are different screening requirements. So a high-risk provider may be subject to things like fingerprinting and criminal background checks. The ACA also requires states to terminate a provider from their Medicaid program if that provider's billing privileges have been revoked by Medicare or another state Medicaid agency. And then it also requires states to share that information. So if a provider is terminated in California, he can't just run over to Nevada and set up the same sort of scheme. It also requires states to freeze Medicaid payments to a provider where there's a credible allegation of fraud. And I think this is really important for you legislators out there because if a provider comes to you from your district and says, hey, Medicaid isn't paying me, what's going on? You may want to go talk to your state program integrity folks and ask them because they typically have a good reason for suspending payments. And then in effort to minimize improper coding and improper payments, the Affordable Care Act requires use of the National Correct Coding Initiative. Just a couple more here. The ACA has a new requirement that states contract with a recovery audit contractor to recover improper payments. And this is an outside contractor that's paid on a contingency fee. So whatever they recover, they keep a bit of. And it also encourages improvement to the Medicaid Management Information System, Medicaid's claims processing system, and provides federal matching funds for enhancements to this system. Many states, though, are not choosing this option at the moment because it's generally pretty expensive to revamp those systems. So what are states doing to address Medicaid fraud and abuse? The general trend is toward prevention and focusing on providers. Where traditionally states have paid Medicaid claims and then tried to recover inappropriate payments, there's been a huge paradigm shift toward preventing fraud on the front end. And this is really in line with many of the Affordable Care Act requirements that shift shift toward prevention. Additionally, states are focusing their efforts on providers because that's where they get their biggest bang for their buck. Providers are responsible for a significant amount of fraud in comparison to beneficiaries. So many states are working to implement the provisions of the Affordable Care Act. A few have enacted legislation to comply with the ACA. California's law, for example, is fairly comprehensive and addresses most of the provisions in the Affordable Care Act, but Maine, on the other hand, enacted legislation last year that specifically address contracting with the recovery audit contractors. Additionally, moving on to the next box there, at least 9 states have created an independent Office of Medicaid Inspector General that fulfills the program integrity duties, and Michigan is currently considering this option. In order to prevent fraud on the front end, many states are also looking to advance technology to identify suspicious billing patterns and to detect dubious claims before they're paid. Some states have already developed these technologies and are working to expand them and are well on their way. Others, such as Washington, are just beginning to look into them. Washington's bill last year required the Healthcare Authority to really analyze the potential of technology and see if those advanced data mining and predictive analytics technologies were in a place that would actually be helpful to program integrity efforts. And then moving on to the next box, with multiple agencies working to prevent fraud and abuse, some states are requiring those agencies to work together. So, for example, in Oklahoma, last year they passed a law requiring the Program Integrity Unit and the Medicaid Fraud Control Unit to share data and records, which simply facilitates the fraud and abuse efforts. And then finally, in order to increase transparency, many states require annual reports on program integrity activity. This includes things like the number of providers terminated, the total dollar recovery amount from program integrity efforts, and that sort of thing. And Colorado is the most recent state to enact legislation requiring reports. So finally, kind of to bring it all together, states are doing a lot to address Medicaid fraud, waste, and abuse, but there's still a significant amount that can be done. Program integrity efforts are focusing on prevention and providers, and really just shutting down a few fraudulent entities in your state could save you millions of dollars. For example, an orthodontist in Texas overbilled the state Medicaid agency by $2.6 million over 4 years. He was billing for services that were either not medically necessary or for others that he claimed to have provided when he was, in fact, out of town. In New York, the state recently recovered $1.2 million from a single pharmacist who defrauded Medicaid by improperly billing for prescription medications that he had actually bought on the street. And just the other day, investigators in Florida arrested 2 nursing home managers accused of using $2.75 million in Medicaid funds for personal expenses. So you can really see how shutting down just a few bad actors or keeping them out of Medicaid in the first place can help contain costs. And with that, I'll turn it over to John to moderate our Q&A session.
Great, thank you. Just a reminder, if you have any questions, you can use the chat feature in the right-hand corner of your screen. Generally speaking, if you have a question about Medicaid fraud and abuse, that's going to go to Megan, long-term care and managed care to Laura, and other Medicaid questions in general will go to Melissa. All right, let's look at our questions here. Our first question, which I think is going to go to Melissa, is what states are using Medicaid ACOs or are farthest along considering them at this time?
Great, thank you for that question. There are quite a few states that are investigating ACOs. I think of Oregon. Oregon is unique for many reasons, but one of them that we'll be watching it closely is they will be collaborating with Medicare for these patients. And we'll see how that collaboration ends up saving the system money as well as improving quality for some of those duals. Also, Colorado is doing not quite exactly a traditional ACO model, but they have some real rural areas in the southeast corner and in the southwest corner. And so I know we'll be watching to see how that progresses and lessons learned from that demonstration. New Jersey as well is investigating ACOs within the Medicaid program. They've worked closely with some of the hotspotting activities that happen in Camden, so I will be watching those closely to see what the evidence says about some of that intensive case management and really narrowing in on some of your high-cost patients. But in addition to just the state Medicaid ACOs, there's a lot of interest to see what the data says from a Medicare demonstration project that is currently underway. So Medicare is setting up ACOs, and so we'll look to that data and to lessons learned from there about how states can move forward.
Okay, this question will go to Megan. How do states compare when dealing with fraud and abuse?
That's a great question, and states are at all different levels of, or have all different levels of activity going on. A couple of states that are doing a lot around fraud and abuse are Texas and New York, who both have fairly significant Medicaid programs. And some state efforts are just simply more robust than others. So it's really all over the spectrum, and every state program integrity efforts differ, and that's a result of the fact that every Medicaid program differs. So it's all over the spectrum, but depending on what you're looking at, for example, Tennessee has been dealing with Medicaid fraud and abuse in Medicaid managed care because much of their population is in managed care. So it really depends on the state dynamics of the Medicaid program as well.
Okay. This next question is going to go to Laura. Laura, which states have been using managed care for long-term care services for some time, and have they been successful?
So the state that's been doing it the longest is Arizona. They've actually implemented their Medicaid program as a managed care program, and then shortly after that, several years after that, implemented managed long-term services and support. So most of the studies that evaluate the benefits or the challenges related to doing this are really based on Arizona. I'm going to ask Melissa if she has, are there any other studies that you've seen? I've seen, so Arizona is the state that that's been doing it the longest, and that is the one that has been studied the most. And if the person who asked the question would like to see that data, just send me an email at laura.tobler@ncsl.org, and I'd be happy to send that to you, as well as some of the other just general reviews of the of managed long-term services and support evaluations and research. So I can help you with looking back at some of that if you'd like.
Another managed care question. Do states with managed care programs tend to have less fraud?
Well, the managed care organization is definitely a partner with the state, but I'm going to also ask Megan, because she really is she's the expert on fraud and abuse, and I know that the managed care organizations have that as part of their commitment to the state, is to help them with that. So, Megan, if you'd make your...
Sure. States, because they're just getting into Medicaid managed care in a lot of cases and increasing the number of folks covered that way, are also currently developing how they deal with fraud in managed care, and it really depends on the state. As Laura mentioned, managed care organizations, as part of their contract with the state, does include some fraud prevention efforts and then also internal audits. However, some states are finding that that's not enough, and that they also, from the program integrity side, need to do their own audits of managed care claims and billing and that sort of thing.
Okay, this next question will be our last question. It's going to go to Melissa. Are there any states that have placed a cap on Medicaid spending as a percentage of the state's general fund budget? What about cap per member per month cost?
As I mentioned, that is an area that is definitely of interest to legislators, and Massachusetts and Utah have both looked at that and are working with CMS to see if that's possible. I think one of the things to consider when you talk about putting caps on growth, that as an entitlement program, and as we saw that at least under this recession, the growth has really come from enrollment, that doing caps on the growth of per member cost while it might help to contain costs, might not actually get at the enrollment issue since it is an entitlement program. But yes, that is something that states are investigating and looking at closely.
Well, thank you everyone for taking the time to join us today. Later we'll be sending you a short email survey. We'd appreciate it if you wouldn't mind filling that out. The next webinar in our 2013 Top Issues series will continue to focus on health, diving deeper into the question of what's next for states as they face decisions and deadlines relating to health reform. That webinar will take place this coming Monday, February 4th. Thank you all very much.